Dr. John Bennett broadcasting from Kathmandu, a cyber cafe in Kathmandu, Nepal. This is a regular weekly hangout of the ACNS Neurosurgical Student Society. Tonight we have the pleasure of once again having Juma Magogo. He's a neurosurgeon from Tanzania, now doing a rotation in New Delhi. Before I turn over to Juma, let me introduce the panelists. The main man, the dog, Simon.
Hello, everyone. Nice to be here again, working with you all for these wonderful conferences. And so I'm looking forward to this. Thanks very much.
Welcome, Simon. Simon's in a cold Japan. And Rakesh.
Hello, everyone. I'm Dr. Rakesh Evi, neurosurgery resident from India. Been a part of Neurosurgical TV. It's a pleasure to be the part of this talk today. Thank you so much, Dr. John and Dr. Simon. Thank you.
Welcome, Rakesh. He's been doing this for a while now. And a new guest, Pradeep. Could you please introduce yourself?
Yeah, hi, everyone. My name is Pradeep, and I'm a software engineer from last 5 years. So I'm here just to join you. And I was invited by John, and I caught him on Facebook. So nice to be here with all you guys. And I think it will be fun to work with you. Thanks.
Yeah,
nice to meet
welcome,
you.
Pradeep. Yeah, we're trying to develop a new interface for these conferences so that everyone attending can be identified by the picture, and you can network. And I am the other person at the conference because that's one of the benefits. Okay, welcome, Juma. It's all yours.
Thank you, Dr. John. Thank you, everyone. Let me screen share my PPT, and then you tell me if you can see it.
Okay. Oh, we're back to your face. You could... Yeah, you'll get it. It'll come back. You almost had it before.
Okay.
The way I do it, Juma, is I minimize my Hangout and then open the PowerPoint.
Yes, I've done that.
And then come back and share the screen.
Can you see?
Click on the arrow. There, you're okay. You're sharing the screen, but the wrong screen.
The wrong screen. Okay.
You picked the wrong screen, so you have to. Yeah, there you go. And now you just open your PowerPoint now from right from there. There you go. Spine surgery positioning. Got it. Excellent.
Okay, so I go back.
Yeah, that's fine. That'll do. Oop, fell off again. Because I think you try to make it. Sometimes when you make the screen big, it disappears.
Okay.
Yeah, that's a funny thing about Hangouts. When you maximize it, you had it good for. Yeah, that's perfect. 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 Okay, Juma, could you say a little bit about yourself, where you're from, and where you're practicing and stuff first, please?
Good evening again. I'm Dr. Juma Magogo Mzimbiri from Mwimbili Orthopedic Institute in Dar es Salaam, Tanzania. But I'm currently doing my fellowship at BL Kapoor Hospital in Delhi, India. And I'm doing my fellowship in spine surgery. So I thought like, I've kind of selected this topic because it's important for us as surgeons, it's important for neurosurgeons, for orthopedic surgeons, for residents to understand the positioning and the techniques in spine surgeries. So together today we are going to see this for almost about half an hour. Okay, John, can I start?
Yes.
We know currently there are a number of spine surgeries which are being done all over the world, and for the past 2 decades, the instrumentation fusion spine surgeries have increasingly become common, and there are a number of surgeries, from open surgeries to minimal invasive surgeries, which is currently being practiced all around the globe. So I thought our residents need to know how important is positioning in spine surgeries. Positioning does not only give you comfort during surgery, but it also needs to make patients comfortable and safe, as well as just to make sure that you can easily go to your pathology and intervene it. So there are a number of fusion surgeries. You can see from this picture, this is just a lumbar spine, but we have anterior lumbar interbody fusion. This is a minimal invasive surgery together with D-leaf or X-leaf. We also have a common one, a transforaminal lumbar interbody fusion, and the posterior lumbar interbody fusion. But there are other surgeries from the cervical, from the thoracic, like the ACDF, like we have anterior corpectomy fusion, anterior cervical corpectomy fusion. We have also anterior cervical disc replacement. We have also surgeries in the thoracic spine, and all these needs different approaches and different positioning. So today we are going to see the most common spine surgeries positioning. When we talk of spine surgery positioning, we are actually talking of we are actually looking on the patient surface plus the physiological positioning in OT. And a standard guideline was once made by some of our colleagues. You can see this book, Perioperative Standards and Recommended Practice in Theaters. This actually gives us a guideline on how to position patients in theaters. You can see the guideline states that the patient's positioning should provide the adequate exposure needed by the surgeon for the procedure. The IV and the monitoring lines should be accessible, and the position should not compromise the patient's circulatory, respiratory, musculoskeletal, neurological, or integumentary structures. Now, this is one of the devices we have here in BLK Hospital. We can see here, these are the chest rolls. You can see the arm bolts and the jelly pads. You can see the pillows here. You can see the knee pads. You can see a mattress here. Plus a number of other devices which, as we go on with the presentation, we are going to see them. But all these are essential for positioning in theaters. So our objectives will be to provide knowledge on common surgical positioning of patients during surgery, also to identify and develop awareness of potential complication in patient positioning, to practice measures to avoid injuries and other complications to the patients during surgery, also to promote safety and safeguarding patient well-being during intraoperative period. One might ask, why are we so much concerned with the patient's positioning in theater? One may underestimate this, but actually severe complication, although rare, but they can occur. Can you hear me? Hello?
Yes,
Yes, we can hear you. Yes, we can.
Okay. We have some of the complications. We have this one. This is post-operative or perioperative peripheral nerve injury, which has an incidence of 0.1%, and it's caused by stretching or compression of the peripheral nerves, median nerves, ulnar nerves, perineal nerves in the lower limbs or upper limbs. But it's common for the brachial plexus, and which accounts for 20% of all anesthesia-related injury malpractice claims. We also have isolated single nerve injury, like ulnar nerve, and which accounts for 28%. Ulnar nerve is the most common reported injury, but we can also have median and radial nerve injuries as well. And this has been reported by this girl, Kamal, and his team. Again, patients may end up getting, there's another complication, but I will list it later. It's not here, but it's the postoperative optic neuropathy. I mean, postoperative visual loss, but I'll discuss it later. I cannot see the slide here, but when we go and we will find it, we'll discuss it. So an understanding of the anatomy and the physiology is important in patient's positioning. Integumentary systems, forces include pressure, shear, friction, and maceration. When we discuss of vascular system, an understanding of the dilatation of the peripheral vessels, which may lead to drop in blood pressure. And at this point, I should point out that anesthesia, the general anesthesia also has a lot of complications to the patient's physiology. Some of the general anesthesia may cause dropping of the blood pressure as well. Positioning itself also may compromise peripheral blood vessels. For example, if the abdomen is compressed, you may end up getting compression of the inferior vena cava. So venous compression may predispose the patient to thrombosis, but it may also predispose you to bleeding during surgery. Nervous system, compression of the peripheral nerves, ulnar nerves, median nerves, radial nerves, also brachial plexus. Pressure of the nerves may lead to temporal or even to permanent damage. When we look on the respiratory system, also it is affected. Alteration in diaphragmatic movements and the lung expansion. When at this point, you should know how to put your chest rolls to make your abdomen free when you are operating the patient. So if you incorrectly put your chest rolls, you may end up getting up inadequate tissue oxygenation and perfusion. You may compromise the lungs. Also, musculoskeletal system, loss of control from normal range of movement. It may result into joint damage, muscle stretching, strain, dislocation, and the potential of pressure formation, bed sores, and other things. So an understanding of the anatomy and the physiology is important, and we see here there are a number of pressure points one has to look when he's positioning the patient. It goes up from the occiput, from head to toe, occiput, periorbital arc, zygomatic arc, mastoid region, acromion, scapula, thoracic vertebrae, the iliac crest, the greater trochanter, the medial and the lateral femoral epicondyles, the tibial condyles, malleolus, olecranon, sacrum, patella, and the calcaneus. All these are the potential pressure points that may be, if incorrectly positioned, might end up into getting pressure sores or getting nerve injuries. So one has to be careful with these pressure points, depending on which position. Is it prone or supine or lateral decubitus? Also, understanding of the associated risk factors, advanced age, the nutritional status, because adults and pediatric group are different, and they are differently affected by general anesthesia as well. So an understanding of the age of the patient is important, and this can be, this history can be taken before the patient is taken to theater from the checklist. So the charts can show you the age of the patient. You can also talk to the patient. You can assess the nutritional status. You can also assess the respiratory disorders. If any, if the patient is a chronic smoker, a cigarette smoker, you can also assess this from the history or from the conversation with the patient. Circulatory diseases, obese patient, chronic immobility, any medication, if the patient was using any medication like blood thinners, underlying medical problems, nature of surgery, all these can give you a clue of what to take care of and what you should be looking at when you are positioning the patient. This was the other slide I was looking, but it was about postoperative visual loss, because poor physiological position can lead into perioperative peripheral nerve injury, as we have seen it, or it can lead to postoperative visual loss. This may seem like it's not going to happen, but it may happen, and the cases of these postoperative visual loss have been reported. The postoperative visual loss incidence can go up to 0.2%, and it's mainly caused by ischemic optic neuropathy, and sometimes by central retinal artery occlusion. So depending on, especially in the prone position, patients tends to have edema in the eyes, and which can lead to a postoperative visual loss. And this most commonly is common in procedures which takes more than 6 hours. Like for spine surgeries, we have correction of scoliosis, deformity. This can take up to 6, 7, 8 hours, depending on the level, how many levels are you fixing. Also, instrumented spine surgeries, the same to scoliosis, can also take longer if you are doing many levels, and this can predispose the patient to postoperative visual loss. Also, factors affecting autoregulation, like we have discussed the risk factors, age, hypertension, because a patient who is hypertensive has also risk of getting optic neuropathy, diabetes as well, atherosclerosis, vascular endothelial disorders, and high cholesterol. All these can predispose or can precipitate the visual loss. It's important to note here that the mean arterial pressure is equal to arterial blood pressure minus the intraocular pressure. Or sometimes it can be also arterial pressure minus the intravenous pressure. So it is the intraocular pressure which is mostly affected by the general anesthesia or positioning. As we can see here, the intraocular pressure is increased during prone or trundle back positioning, but it tends to decrease during supine position. So prone position and trundle back position increase the IOP, and therefore, if the IOP increases, then we expect the mean arterial pressure to decrease, and this is a risk. So prone position and trundle back position, one has to be very careful with this position. So the goal of patient positioning is promote proper physiological alignment, minimal interference with the circulation, protection of the skeletal and neuromuscular structures, optimum exposure of the operative and anesthetist site to provide patients comfort and safety, to maintain the patient's dignity, also stability and security in position, because patients also tends to be, when they are positioned in the bed, they have to use stirrups to make them not fall down. One thing to remember also, positioning takes a lot of people, from anesthesiologist to the surgeon himself, the nurses, and the technicians in theaters. All these are involved during patient positioning. And therefore, for the nurses, they should be knowledgeable on the table mechanism and how to prepare the table attachment and accessories. They should also be familiar with the various patient positioning for optimum surgery. The placement of patient to comfortable position, correct position placement when a table break is needed intraoperatively. They should also know, the nurses should also know how to prevent interference with the respiration while moving. So to start with, we are going to see how we are going to position patients in prone position. Prone position is very common for procedures such as decompression, laminectomy, discectomy, fusion, osteotomy, vertebroplasty, and kyphoplasty. And this is the bed. This is one of the bed which is used. We can see here, this is the face pillow. This is the face pillow, which is used to protect the ears, the eyes and the nose, to make them free when you are doing surgery. You can see this is the flame, Wilson flame. But in other cases, they use chest rolls. Like in our hospital, we use the chest rolls. But this is a Wilson frame. You can see the arm boards. These are the arm boards here. The gel pads are not shown here, but they you might need to use them during the procedure. So how to achieve this prone position? Patient should be placed on 2 bolsters or a support device with the arms to the side of the body. And the bolster should be sufficiently far apart. And the reason of doing this is to avoid compressing the abdominal and the femoral venous return. Like we have said, the intra-abdominal aorta and the inferior vena cava in the abdomen. You should always avoid increasing the venous return or to compromise any venous return. So when you are positioning the patient on your Wilson frame or on your chest rolls, the abdomen should be set free. And one chest roll has to be positioned on the chest. The other one has to be positioned close to the 2 inches above the knees. Also, this will allow you to have adequate diaphragmatic excursion. So you have to ensure all the lines, like the IV lines, if you are using also intraoperative nerve monitoring, you should also make sure that they are secured, well secured. 2 assistants should stand on free side of the table, another 2 on the free side of the trolley, and 1 should manage the feet and 1 should manage the head. So the anesthesiologist will stand on the head. The other 2 guys, another 1 will stand on the feet, and the 2 on the lateral sides, on the right and left. Because before the patient is positioned in prone, firstly the patient is positioned in supine, and then it will be turned into prone position. So around 6 people are needed for positioning the patient in prone position. Before you turn the patient into prone position, you should connect all the lines, and they should monitor the lead, the ECG leads, and secure them. The signal person from the person managing the head should disconnect the patient from the anesthesia machine and turn him gradually onto the outstretched arms of the receiving assistant. You should also hold the arms alongside the body, the head in sagittal plane during the turn. And then soon after positioning the patient on prone, anesthesiologist should connect and auscultate the chest to confirm the ETT position. Patient should remain supported by the appropriate chest rolls. And when you are positioning the patient in the prone, you should start from the head to the toe so that you avoid going back and coming back. You should start from the head, then come to the chest, then come to the abdomen, then come to the thigh, then come to the knees, and then you finish with the toes. So maybe we can understand better from this picture here. This is the lady who has been put on the chest rolls. One is set on the chest, and the other one was put on the waist, or the other one was set on the waist so that the abdomen is free. You can see the arms here, they are abducted at around 90 degrees. Do not abduct the shoulders more than 90 degrees. Again, you can see the stirrup here, just to make the patient safe in this position. In our case, we use the knee pads. But as for this bed, they do not use the knee pads. The knees are just hanging. You should also make the foot in a dorsiflexion position, and you should make the toes hang freely. So first pillows with the eyes and nose free of compression. Arms should be on the alongside the head. Avoid the pressure on the abdomen. You should avoid the pressure on the male genitalia or breast. For women with larger breasts, some surgeons may suggest using the lateral position. But depending on the procedure you are taking, you can still position the patient on prone. But care must be taken on the male genitalia or the breast. The arms and knees should be padded. The ankles are elevated for toes to hang freely. According to Kamal et al., this horseshoe headrest has been associated with the central retinal artery occlusion, and which may lead to postoperative visual loss. So some may suggest use of Mayfield head holder instead of using the horseshoe headrest. So let's see on the cardiovascular system. Venous pulling may reduce cardiac filling pressure and the cardiac output. Improper positioning may obstruct the femoral and the inferior vena cava and may lead to the dropping of the blood pressure and the venous return. Wrapping the legs with elastic pneumatic stocking can maintain the filling pressure. Again, with the respiratory system on prone position, if allowed to breathe spontaneously, it has to move the entire thoracic mass of the sternum to expand pleural cavity. Also, weight of the dorsal trunk push abdominal context cephalad, which may push the diaphragm and therefore increase the WOB. If the chest rolls are correctly pressed, the chest and the abdomen should hang free, as we have spoken. The ventilation should be accomplished with normal pressures, and the functional residual capacity decrement seen in supine position is not seen with prone position. Again, this is the central nervous system. Some of the vertebral venous plexus, commonly known as Batson plexus, have an anastomic connection with the inferior vena cava. So when you compress the abdomen, you may find yourself getting a lot of bleeding, and which this may compromise your vision during spine surgery. So always make sure the abdomen is free, because when you compress it, there will be more venous pressure, which may go to the blood may go to the vertebral venous plexus and may make more bleeding into the surgical site. So to finish up, when the patient is positioned properly in prone position, then these are what we expect. Free abdomen will lead to less motion and less bleeding, and it may also decrease the barotrauma, and it may reduce the CSF flux. Care should be taken on the brachial plexus when you are abducting the arms and elbows and shoulders. Make sure the shoulders or elbows are not extended more than 90 degrees position. It should be 90-90 position. The elbow should be anterior to the shoulder to prevent wrapping of the brachial plexus around the head of humerus. And it's more safe to put the patient in supine, to put the arms in supine position rather than pronation, because this pronation may increase the risk of ulnar nerve injury. So these are the pressure points to be considered when patient is put in prone position: the ears, the eyes, the cheeks, the acromion process, the breast, the anterior iliac spine, the male genitalia, patella, and the toes. So these pressure points one has to take into consideration when positioning the patient in prone position. They should all be well padded during the procedure. As I've said before, some surgeons suggest use of Mayfield head holder, but this depends on the surgeons and depending on the procedure. Like Mayfield head holder may be used in posterior cervical instrumentation. It may work well, but for other procedure like ACDF, some surgeons may just recommend the use of just a face pillow. So it depends on the surgeon's preference, but again, it may also depend on the type of the procedure you are using. Some of the complications are listed here. Compression neuropathy, we have discussed the ulnar peroneal nerves. So to avoid this, padding over the elbows and use padding over elbows and avoid pressure on the posterior popliteal fossa. Also, anterior tibial compartment syndrome, it may occur, and especially it has been reported with the use of Andrews frame. And this is an emergence which may require emergency fasciotomy. Pressure on the eye, as we have seen, use the face pillow, which will make the eyes and the nose free. For the cervical spine injury during positioning, some complications, cervical spine injuries may occur during position due to relaxed muscles and anesthesia. So one should take care, especially the anesthesiologist should take care of the head when positioning the patient. This is the way to do open lumbar laminectomy, but I'm not going to discuss this, but it was the how one would do the open lumbar laminectomy procedure, but we are not going to discuss this today. This is an example for a case, a 49-year-old patient who came to us presenting with chronic lower back pain, which was associated with claudication and radiculopathy. You can see this is the MRI showing this is L4, L5 degenerative disc disease with compression from the disc and also from the ligamentum flavum here. So there was some kind of canal stenosis because of the disc and the ligamentum flavum hypertrophy. In general, this is a degenerative disc disease. And one can see the disc here, which is bulged and is compressing the thecal sac. And this was the procedure which was done. This was the minimal invasive surgery for transforaminal lumbar interbody fusion and fusion. You can see this is the cage, and these are the rods and instruments which has been placed. It's one of the case, and this was the surgery. Another position is supine position. It's very common for the ACDF, anterior cervical discectomy and fusion, anterior cervical corpectomy and fusion, anterior cervical disc replacements. Also, it may be common. These are among the reasons why patients go for operation. Patients with deformity or kyphosis on the cervical, kyphotic deformity like on the cervical spine, patient with instability, or patient with neurological compulsion. All of these may need one of these procedures, depending on the pathology. So this is the way to position the patients. You can see this is the C-arm fluoroscopy, which is used intraoperatively for localization of the pathology, as well as when you are putting the instrument, or when you're putting fusion, or when you are putting the screws and rods. So the position is positioned in supine. You can see the use of the headrest here. You can see the arms are put alongside the body, and they are well protected by some sort of a piece of a cloth. You cannot see the knees here, but the knees should be padded, just like the arms. The arms are padded, but the knees should also be padded. The heels should also be padded. So in supine position, the physiology behind is careful push of diaphragm may decrease the functional residual capacity by 1 liter, and it may increase the closing volume. So alveoli closes at a volume very near to the forced residual capacity, and the distal airway cannot participate in the gas exchange. So there is a ventilation-perfusion mismatch, and therefore reduce compliance. And some of the general anesthesia have effect on the functional residual capacity. They decrease the functional residual capacity. And all these may compromise the respiration during surgery. Again, cardiovascular system may also be compromised. There could be increased venous return and therefore increased cardiac output, and therefore baroreceptor reflexes may go down, may cause to heart rate going down, and therefore cardiac output may decrease. Also, sympathetic tone may decrease because of decreased heart rate and MAP. So anesthesia, some of the general anesthesia may cause muscle relaxation, and the PPV may interfere with the venous return and the autoregulatory mechanism. So circulatory effects of positioning may remain uncompensated in such patients. What is important in this, head is important when you are positioning the patient in supine, but you should also remember the upper limbs should always be at the sides. They should be, do not abduct the shoulder for more than 90 degrees to avoid stretching or compression, stretching of the brachial plexus. Padding should be used as we have discussed on the pressure points. The elbows, the wrists should be padded, and all this is to prevent ulnar and medial nerve. The knees also should be elevated, should be padded on the popliteal side, when you are putting the patient on the supine position. And this may decrease tension on the lower part of the back as well. It may relieve pressure on the back muscles. The heels should also be padded. You can see here how to position the patient on supine, and this angle should not be greater than 90, so that to avoid the most common complication, which is brachial plexus injury. These are the pressure points to consider: the thoracic vertebrae, the scapulars, olecranon, sacrum, coccyx, calves, and calcaneus. All these should be taken into consideration when you are positioning the patient in supine position. Because we have discussed much on the prone position, we'll be quickly going through the other position, because the knowledge behind this, as we have discussed, in prone position. So these are the pressure points in supine position. This is one of the procedure, ACDF, how it's done, but again, we are not going to discuss it because it's not our topic today. This is one of the case which presented to us with the history of upper limbs weakness and pain, and they had poor grasping. And you can see here, there is canal stenosis at around C4, 5, and C5, C6. And ACDF was done to put a plate and the interbody cage. So this was the procedure which was done, and the patient post-operative was doing fine. This is another procedure very common in spine surgery, anterior cervical corpectomy and fusion, but we cannot discuss because of time. You can see the pictures here. This is pre-operative, and this was post-operatively. Anterior disc replacement also is one of the procedures, but it's currently discouraged nowadays. But you can see this is the disc material, which is used to replace the degenerated disc. And you can see this picture here, post-operative picture. Another position, and the last position we are going to discuss today, is the lateral decubitus position. There is some of the key anatomical structures to consider when you are putting the patient in the lateral decubitus position. Includes the lumbar plexus. These are the peritoneum when you are going through the psoas muscles, sympathetic chain, which is located on the psoas muscles. The superior hypogastric plexus also is located on the psoas muscles. So these are the structures one should look up when he's putting the patient on lateral decubitus position. So the lumbar plexus is contained within the transverse psoas muscle, The genitofemoral nerve runs superficially on psoas. So sensor will not be detected by EMG, electromyogram. Some doctors recommend the use of neuromonitoring during these procedures so that you cannot damage the lumbar plexus. Femoral nerve and other elements of lumbar plexus are at risk when we are doing this procedure, especially because during the dissection, the psoas muscles will also be dissected and retracted. So a care should be taken when you are doing trans-psoas approach. And this is the setting up in the OR. Anesthesiologist should be on the head while positioning the patient. The other two surgeons and nurses will be on the lateral sides, and one will stand on the feet. And you can see here, this is the C-arm, is positioned here. Also in this position, you need to support the patient with some devices, supported devices. We are going to see those devices. You can see the legs here, the pillow is placed between the two legs. The knees should also be padded. Also the arm is also padded here. And the neuromonitoring specialist is sitting somewhere far from the patient. So in lateral position, in order to maintain the lateral position, a support placed along the patient's back and abdomen should be placed. The knees flexed with paddings between the knees to avoid pressure over the vestibular head and the perineal nerve. So this is the support which is placed here on the abdomen. This is on the abdomen, and this is the neuromonitoring device which is put here, and all these lines should be well secured and should not interfere with each other. You can see also this is the support which is put on the back, so that's for patient safety. You can see the pillow. You can see also here the pneumatic or compression stockings, so that for maintenance of the blood flow. This is anti-DVT stockings. So in lateral position, the physiology behind is the respiratory system. The lung will be, one lung will be below and the one lung will be up. So non-dependent lung is well ventilated, but it is poorly perfused. And the dependent lung is well perfused, but it will be poorly ventilated. So there is still a ventilation perfusion mismatch. And this may decrease the MIP. When your cardiovascular system, MIP might decrease in the lateral position. But most of the time, the heart rate is unchanged. So these are the pressure points also to consider when you're putting the patient in lateral decubitus position: the ear, the acromion process, the olecranon on the elbow. You can see the ribs, the iliac crest, the greater trochanter, the medial and the lateral condyles of the femur, and the medial and lateral malleolus on the tibia and fibula. So what are the complications in lateral decubitus position? Some patients may end up getting thigh numbness because of genitofemoral nerve trauma, because this nerve cannot be monitored by electromyogram. But this one is usually transient and it resolves in approximately 2 weeks. Some patients might end up getting thigh flexion weakness because of the this is psoas muscle injury. It's not positive. It's psoas muscle injury. The risk increases if more than 2 levels are done, but it's usually transient. It may also go away after 8 weeks. The quadriceps weakness may also be present after postoperatively because of the nerve root and the plexus injury, probably because of the psoas retraction or hematoma. But this may improve slowly over a long time. So when you are doing consent, you should always remember to mention this complication to the patient, so that the patient becomes aware of the possible complications. But with well padding, with well positioning, you may avoid all these complications. This was how to do this procedure in lateral. This is lateral lumbar interbody fusion. Some people also call it. It's also known as direct lumbar interbody fusion or far lateral lumbar interbody fusion. But we are not going to discuss this because this is about the way to do it, the procedure. I will just go quickly. One might be interested, but we are not going to discuss this. So I have made a case here also. This is an 85-year-old man who presented to us with a chronic lower back pain and a kyphoscoliotic deformity. DLIF was performed, and the patient was awaiting minimally invasive transforaminal lumbar interbody fusion. You can see, this is the patient. You can see kyphoscoliosis at this level. This is L3, L4 level, and the L2, L3 level as well. So kyphosis or deformity is one of the reasons why we do surgeries. And you can see in this patient, the best procedure, the best position was to put the patient on lateral decubitus position so that you can put the cage on this level here. You can see this is the X-ray. You can note here the degenerative disc disease, spine disease, as well as the deformity. You can see these are the cage. These are the interfusion. This is the interbody cage here, which was placed. And you can see the restoration of the normal disc height. Initially, the disc height was compromised, but now you can see the normal, the kyphosis has been corrected and the disc height has been recovered to a normal disc height. And this patient was awaiting another procedure, the transforaminal lumbar interbody fusion, for fixing the spine from the posterior element. So that's all for today, and that's what I wanted to share with you guys. Just the positioning, the physiology behind, and how to avoid this complication. Thank you so much.
Thank you, Juma, for an excellent presentation. Very clear questions, and I'm sure the people in the panel enjoyed it. Well, I'd like to start things off with just a general question. Well, I'm not a neurosurgeon, basically a regular MD, and it has to do with regarding how much of a role the neurosurgeon plays in the positioning of any procedure. Do you pretty well become acquainted with the patient's medical background, and do you go over the positioning with the anesthesiologists and nurses before, or do they already understand?
Say again, sorry.
Do you go over the positioning of the patient with the nurses and the anesthesiologists before every case, or they kind of know it already?
We have to be, before positioning the patient, the surgeon should be there. This is the protocol in this hospital. The surgeon must be there, and for the head, when you are positioning the head, the anesthesiologist should always be there when you are positioning the patient. All the nurses and technicians in the theaters are aware of the positioning, but they should wait for the main surgeon to come and they share which position does the surgeon prefer, or share any risk factors and share anything. So I can say the whole team in theaters, from the anesthesiologists, the surgeons, the nurses, the technicians, are all concerned during positioning of the patient. They are all involved, and because position needs at least more than 5 or 6 people for proper position.
Really? Okay, but I imagine the team kind of gets to know the procedure and the positioning. Is that true? They pretty well know before you come in there and review it. They kind of know it.
Because of most of the nurses are trained and they are experienced with the positioning. So always they know how to do it, but they should just wait for the leader, and the leader,
Right.
the leader is always the surgeon.
Right. You're responsible.
Yeah, you should be responsible. There's always a responsible person in the team. So the surgeon is the responsible person, and they should always wait for the surgeon to come before positioning the patient.
Okay, so the neurosurgeon just doesn't scrub up and show up to the operation. You have to show up well before the procedure starts, correct?
Yes.
Like if the procedure's at 8 o'clock, you just don't show up at 5 of 8, scrub up and jump in. You have to be there maybe 20 minutes early to make sure the patient's positioned correctly, right?
Exactly.
Okay, that's something I didn't know. I didn't know that. So, Rakesh, are you there? And I don't know, Pradeep, do you have any comments or questions? As a software developer.
It's like, a different thing for me. But yeah, that BL Kapoor Hospital is near to me.
Okay.
Yeah, you guys are both in New Delhi.
Yeah. He is in New Delhi, and I have a friend, and she's a nurse. So she worked in BL Kapoor Hospital.
Okay.
Yeah. So.
Okay, very good. Speaking generally again, Juma, is positioning of spinal patients, is it a bit more complicated than head cases, or they're both pretty complicated?
In my opinion, positioning brain surgery is much more complicated than the spine.
Much more complicated?
Than the spine.
Okay. One thing, you brought something up that I was starting to think about. You have to be acquainted with the medical condition of the patient and the history before you go in there and position the patient. Because that's what I got from your presentation today, is that you kind of have to know what's going on medically with the patient when you position them.
Yes.
So the surgeon has to know a little bit about medicine besides the neurosurgery.
Sure. All these are the risk factors. Some diseases like diabetes, we know diabetes has many complications. Some of the complications are peripheral neuropathy. It could be vasculopathy. It could be nephropathy. So all these complications has been known, because the problem postoperatively, when you are assessing the patient, you need to know if these symptoms were there before the surgery, or they just happened after the surgery. For a patient who is diabetic, who has peripheral neuropathy, the nerve, when he complains of the nerve numbness, this might be because of the disease itself, not because of the positioning. But again, it might be the disease, the positioning accelerating the disease. So all this has to be known. The risk factors, smoking also has to be known. The cardiovascular problems, if the patient has any hypertension, so there is the risk of decreasing MAP, or patient getting hypotension during the surgery, which may compromise the mean arterial pressure. All this has to be known, because it might be the disease accelerating because of the positioning. A patient who is hypertensive with retinopathy is at a higher risk of getting postoperative vision loss, because he has already visual retinopathy. Plus positioning, if the patient is positioned in prone position or Trendelenburg position, which you have discussed, that has increased risk of increasing the intraocular pressure, all these might make the patient at risk of getting postoperative vision loss. But it's rare, but it can happen.
Well, you know, generally speaking, most patients have to be cleared medically, or they're seen by a medical doctor before their operation, or just in patients with medical problems.
They have to be cleared before. So if it's the patient, it has to be, if the patient, for example, is diabetic, has to be seen by a medical specialist times before the surgery. If the patient also needs to be seen by an anesthesiologist for the to know the kind of drug the patient is using, which may be may be compromised by the general anesthesia. So all these specialists might be involved. The anesthesiologist are involved prior to the procedure. For example, in our case, if the patient is using blood thinners, the patient has cardiovascular diseases, and is using antithrombotic agents, this has to be stopped at least 2 weeks before the surgery. This has to be known to the anesthesiologist team, so that to avoid all the risk. Intraoperatively, when we are putting the patient in positioning, all the nurses have to know this also, because it's part of the job to make sure if there is any risk, they have to document. If the patient was in any medication, the nurses have to report this. So everyone in the team in theater has to know the risky factors. The surgeon should share the information with the rest of the team.
You know, I guess you answered part of the question. My next question was, I guess the anesthesiologist obviously has a role in advising you what position, correct? Because they're really concerned with the intraoperative blood pressure. So you consult with the anesthesiologist typically before an operation, or you just kind of do it yourself?
No, we have to communicate. Always we have to communicate with the anesthesiologist too. Actually, the anesthesiologist comes first in surgery in theater to prepare the medications for general anesthesia. Again, the surgeons comes and share any information, and they kind of exchange what should be done together with the surgeons. But it's the task of the general anesthesia, if the patient has diabetes, to know that which medication, which drug should be used for anesthesia. So because he's the one who is going to control the respiratory and the cardiovascular system.
Very good. I think Rakesh was called to the hospital, and you can relate to that, Juma. Okay. Are you there, Rakesh? I think he had to go to the hospital.
Okay.
And in closing, Pradeep, do you have any comments or for Dr. Magogo?
No, not right now.
Thanks for coming, Pradeep. And one thing I want to say to you, Juma, we're having a live streaming conference from Mombasa.
Okay.
Not far from your home in Tanzania.
Yes.
On Thursday, Friday, and Saturday. So you're welcome to come join us. It'll be on from 8 to 5 for 4 days actually, Thursday, Friday, Saturday, and Sunday. And I'll send you the program. And another thing is that you may be interested in doing a month fellowship with Ipe Cherian up at Nobel Medical, and he'd love to have people like you come up there for a month, 2 months. Okay. You really get to know the neurosurgeons well.
Sure.
Anyways, thank you for a great presentation, and we look forward to participating with you more.
Thank you so much, and I'm sorry for the noise interruption here. The place I had today, the room is closed. The room is closed, but I had to use the open space here. So there was a bit of cleaning here, and then.
Okay, thanks for coming, Juma. I'll send you the link to the video. Thank you.
Thank you so much.
Bye-bye.
Bye-bye.